Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Grace Terrell. She's a physician executive, and today's Kevin MD article is Physicians Must Innovate and Focus on Medicine's Core, Not Chores. Grace, welcome to the show.
Thank you. Glad to be here.
All right. So just tell us a little bit about your story and then jump into the Kevin MD article that you shared with us.
Absolutely. So I'm a general internist. I've been in practice in medicine in one form or the other since I got out of training in 1993. Along the way, I've done things such as run a large independent multi-specialty medical group in North Carolina called Cornerstone Healthcare. I've had the honor of, beyond that, doing some things like running a whole genome sequencing company in rare disease and working in a integrated primary care and mental health model in the long-term care space. Currently, in addition to continuing to see patients on a regular basis, I'm the chief medical officer of a company called IKS Health, and everything that we're focusing on right now is about understanding and working to solve this core versus chore dilemma.
All right. So tell us more about the core versus chore dilemma, as you put it.
Okay. So I think what's happened to physicians over the course of my career has been that there has been a real problem with what ought to be the actual practice of medicine, our core mission of taking care of patients in the way that we've been trained and ought to be doing, that has been displaced by more and more and more chores
Mm-hmm.
that are getting in the way. Most of them are technology focused or their payment system dysfunction focused. It has to do with the hours and hours that we spend on documenting in the electronic medical record. It can have to do with things such as the unfortunate work we have to do around things such as prior authorization. All of these things have happened for a reason that have to do with the focus on making sure that the right types of payment gets done.
Mm-hmm.
But in the way, what's happened along the way is that as a result of that, less and less of the actual core work that physicians ought to be doing is being done, and more chores are in the way.
So you mentioned you're a general internist, as am I. So just to give an example for those listeners who may not be familiar with the day-to-day obstacles that we internists or physicians face, just give us an example of some of these chores that we're talking about that gets in the way of the core work that you do.
Well, a lot of it is administrative. It's the fact that we're mostly doing data entry right now. So if you think about the types of work that you've probably done over the course of your career, I've certainly done over mine. The best part of what we do is listening to patients, making the appropriate diagnosis after we hear their story and examine them after we get the appropriate type of test, and making sure that they get the right types of treatment if it's something that needs treatment. And although that tends to be what gives us joy, is that actual work with patients, it's become less and less of what we do. So much
Mm-hmm.
of the chores that we do right now have to do with clicking all day long on electronic medical records. Things like if there's an appropriate medicine for a patient, having to go through all sorts of processes to get that medicine approved for insurance. A lot of it has to do with the burden of how we have to do clinical documentation now,
Mm-hmm.
get it just right so that we get paid or get paid in the right way. Some of it has to do with more and more inbox type of work that we have to do. Patients like being able to communicate directly now in between visits with their clinicians that are serving their needs.
Mm-hmm.
But much of my inbox that still happens is things that I used to not have to do at all. They were handled by my staff, and now they come directly to me. And much of it doesn't have to be done at all.
Now, if you were to estimate a certain percentage, what percentage of your day would you say is spent on these chores, these inbox related things, these prior authorizations versus directly communicating with patients themselves?
Well, it's interesting when you talk about the concept of a day, okay, because used to that would be the time that you were actually with patients, either in the hospital, in my case, also the nursing home or the clinic, or making
Mm-hmm.
home visits. And it might run, because physicians tend to work long hours, anything from 7 in the morning to 5 o'clock in the evening. Nowadays, I'm an ambulatory physician, so I see patients just in the office. And so during the day, when I'm doing the clinical documentation, probably 40 to 50% of it is actually not in direct patient care, but doing all the clinical documentation, the answering the inbox, the prior auth, and things like that. But there's also the evening hours. There's a term that is being used called pajama time, which I
Hmm.
think is an insult. It basically says that because physicians are typically conscientious people, what we tend to do is we try to do as much as we can during the day. Then we go home, we're with our families, and then we're having to do more documentation. I actually think that's stolen time. It's stolen time by good people that are trying to do the right thing for patients. So if you add that to it, many clinicians are spending sometimes 2 to 6 hours a week in the evenings also doing work, and it's all that work is chore work. It's not the core work.
And we've been talking about this core versus chore debate on this podcast and on Kevin MD for what seems to be years now. And if this doesn't get better, that's going to lead to things like burnout and moral injury and more physicians leaving clinical practice, right?
That's right. And fewer physicians are actually attracted to the types of work that you and I have done our whole careers as general internists, which is that type of work where there tends to be more of this because it's been sort of a clinical documentation game that's happened over the last few years. So it has to be solved. I think it's one of the major reasons that we have a primary care shortage in the country
Hmm.
right now. I have a daughter who is a pediatric intern at the University of North Carolina, Chapel Hill, UNC hospitals. And my belief is that my mission in life at this point is to make sure that we get this fixed for her. She'll be a third generation female physician. My mother-in-law was an internist.
Hmm.
And much of what she ought to be doing over the course of her career is taking care of children. There's a huge shortage of pediatricians right now. We need people like my daughter that are going into this. And if we don't fix this, no one's going to go into it. Pediatric residencies weren't getting filled this past year.
So I know that this isn't an unknown problem. We have a lot of different potential solutions that are out there. We have technological approaches like AI solutions, ambient AI scribes, for instance. So, from your perspective, what's the best way to get out of this? What are some of the potential solutions that we can do to reduce the chore work physicians have to do?
I think there's several. One of them is related to understanding what physicians ought to be doing and eliminating all those other things that they are getting in the way by several things. One is, the concepts of having other people doing them for them. If it
Yeah.
doesn't have to be done by a clinician, it shouldn't be. If it doesn't have to be done in person, it shouldn't be. It can be done by other people. It can be done by technology. Part of it, I believe, is the redesign of technology itself. So the company I work for, IKS, we have done a lot of thought about many of the aspects of the clinical work and think about things like virtual medical assistants that can do some of this work. Part of it is our human beings. Part of it is the AI that we have developed around a lot of these chores. But part of it is redesigning the technology and the workflows themselves. So I think that there's been basically 5 stages of health information technology. The first stage was really the revenue cycle management, the billing and scheduling, all that, this sort of 50-year-old technology. And the second stage has been the electronic health records. The third's probably, population health and
Mhm.
longitudinal care. The fourth is the Internet of Things, or what we call remote patient monitoring. And the fifth is AI and predictive analytics. And unfortunately, in healthcare, each of these has a friction point. They've been built one on top of another without really human-centered design as part of it. And so what we have to do as we're in the middle of reimagining what ought to be done is to understand the system that we're in and use people and technology to eliminate those friction points while we're really focused on human-centered design. And in this case, the human being needs to be the clinician, their staffs, as well as what works for patients.
So tell us in your ideal world, what would those improved workflows look like? You mentioned everyone practicing to the top of their license. You mentioned virtual medical assistants. So in your ideal world, just give us a scenario of what that would look like.
Absolutely. So I would imagine that either if it was in person or in some sort of, telemedicine type of interaction with a patient that was seeking my help as an internist or perhaps my daughter as a pediatrician, that when I had that interaction, what was done ahead of time was understanding what had happened since the last time the patient had had that interaction, that the longitudinal care, the gaps in care would have been identified. The type of working around that would have been done by others through reach out and through care management. As I entered a room, perhaps if it's an ambulatory visit, what has happened since that's relevant to the patient in my clinical practice is told to me either in some sort of virtual way or whatever way I need to consume it. I would go in and have the interaction with the patient, and I would not be clicking or looking at a computer the whole time. I would be having an interaction. That interaction would help generate a note. And then the clinical documentation that went along with my assessment and plan and all the things that I need to do for that patient, including being able to just call out visits for call out orders, or which could be evidence-based and perhaps helped with the use of AI to make sure that the right things were done. Were done in a way that all the time I'm looking at my patient, examining my patient, my eyes and ears are focused on the patient. And then after the interaction, if we're using today's time, smooth access for the patient for getting those services are done the right. The patient isn't bankrupted as a result of it. And then the results are come back in a timely way. The patient's questions are asked, and the interaction is one that actually meets their needs. So every single one of those steps, what we've done at IKS is we've actually looked at 16 different places in sort of the patient journey. Some of them are on the administrative side, some of them are on the care delivery side, where we can actually work now with either people or technology to take the friction out of that. But as we move forward, we need to have that being a singular platform, and it needs to be something that works for patients everywhere, any place, anytime. It needs to work for the clinicians as well.
So what's preventing us from reaching that ideal goal? Is it a matter of the technology not being there? Is it a cost issue? Is it a person power issue in terms of staffing? So tell us some of the
There's several
friction points.
Yeah, several points are that much of the staffing is related and has been designed for somebody in the office to do many of these tasks that are just asked, they just put one on top of the other. So, and there's just not enough people that are available with the right skill sets in many offices to do this in a cost-effective way. Some of it is the fact that everything goes back to the point of care and ought not to be part of what the clinical interaction is to begin with. We don't do a good job in our payment system of paying for the longitudinal care that's needed for good outcomes. And so some of it, in my opinion, needs to be about payment reform, which has been shown to make a great deal of difference, and something I've had some background in. I haven't gone into. I actually think that you have to have payment model and care model redesign at the same time to get a lot of it done. And the third component of that is technology redesign. So a lot of what I do and think about in this day and time in my current role is the technology and care model design. But at the same time, I've had some background in payment model redesign in the past. And it's really almost a Rubik cube. You've got to have all of it working together in all the different dimensions to get us where we need to go.
So it sounds like a lot of these approaches are more macro-based approaches. How about for the individual clinician? While we're waiting for some of these improvements to come along, is there anything that individual physician can do to better delineate core versus chore and better make that ratio more favorable?
So I think that depending on the environment that the clinician is in, understand what tools are out there, understanding how to give up things that your staff can do, or that your staff outside of your practice can do for you. So a really simple example that I've seen for years is every single mammogram report still comes back to me for me to sign off on. That's normal. Now, there's no real need for that. What's needed actually is if there's an abnormal mammogram report, I likely need to know about it for one of my patients. Or if my patient didn't get a mammogram, then it may be important for me to know that when I see them in the practice. But all that is right now, at least in our system, designed to come back to me. That really isn't the best work for a primary care physician in my case. It ought to be taken care of by other aspects of how we actually manage those things for patients.
Now, I always like to ask this of my fellow internal medicine physicians. You've been practicing for decades now. You're still seeing patients. Despite all the obstacles that we've been talking about, you're still practicing internist.
Yes.
Why do you stay in the field? What makes you keep on going despite everything that we talked about today?
My practice at this point is very small because of my other responsibilities and things I do in my career. But a lot of these patients I've literally been seeing 30 years, and I feel that I make a difference in their lives. I've experienced, the personal satisfaction of taking care of patients and making a difference. And it's something that I think is really important. And so as I'm thinking about the way to redesign things for the future, if I'm not out there practicing myself, I don't think that I would be nearly as effective. So I think actually being in the trenches where you really understand what the real chores are is the only way that we're going to actually get this solved. One of the issues we've had with our technology oftentimes is that there's not been the right type of design process because the
Mhm.
people that are actually using the technology are not involved.
We're talking to Grace Terrell. She's a physician executive, and today's Kevin MD article is Physicians Must Innovate and Focus on Medicine's Core, Not Chores. Grace, let's end with some take-home messages that you want to leave with the Kevin MD audience.
The first message would be really think about the work you do and determine how much of it is actually chore versus the core mission that you have, and start thinking about how you can redesign in your own environment for that. The second message is to not assume that the current state is where things have to be, and join me to help think about how we might innovate on the spot to actually start where we need to go to actually improve healthcare. The third thing is my personal mission statement, which I hope is something that will resonate with any of you all, and that you might have your own personal mission statement. And mine at this point in my career is I will use my talents, my experiences, and my scars and work with other people to radically improve healthcare. And that's what I'm about. And I hope that it's something that will help for all the clinicians that are out there.
Grace, thank you so much for sharing your perspective and insight, and thanks again for coming on the show.
Absolutely.